Hello, my name is Rohan Joseph. I'm a bariatric surgeon at Capital Regional Medical Center. I am in a group with two other bariatric surgeons, Dr. Anthony Wright and Dr. John Dorch. We have been at this hospital for the last 4 years and been performing bariatric surgery. The goal of this seminar for you, the patient, is to increase your understanding of the surgical management of obesity. We want you to understand today what the criteria are for bariatric surgery and what going through the process of being worked up for bariatric surgery would look like for you. In general, the criteria as set forth include a BMI of more than 40. The BMI is the ratio of your height and weight, and it can be calculated with a calculator found on your phone. You just need to Google in BMI calculator. The additional criteria for weight loss surgery include a BMI of more than 35 with one or more comorbidities associated with being overweight. These comorbidities include having diabetes, having high blood pressure, having a high cholesterol, having sleep apnea, having gastroesophageal reflux disease, having joint problems, headaches, vision problems associated with being overweight. Most patients who are considering bariatric surgery or who have seen a bariatric surgeon in the past have usually had a history of multiple failed dietary attempts at weight loss. It is very important that you be able to comply with the post-operative regimen and the requirements to have surgery safely. From our standpoint, the surgeon's standpoint, the most important consideration for you as the patient is to undergo a safe operation and to take you through this process safely. The most important point I want to leave with you today is that surgery is not a magic fix to fix the weight problem. Surgery is a powerful tool to help you get the weight off, but surgery in combination with diet and exercise will help obtain the best results. Most procedures done for weight loss surgery can be either classified as being restrictive, where they restrict the size of the stomach, or being a combination of restrictive and malabsorptive, where not only do we restrict the size of the stomach, but we also interfere with the ability of the body to absorb some of the nutrients and thereby help losing weight. As our understanding of bariatric surgery has improved over the last couple of decades, we understand that weight loss doesn't occur just by restricting the amount of food that we eat. There is a large component of hormonal changes or metabolic changes that influence weight loss. And that is why today bariatric surgery is now also being called metabolic surgery, because of the changes in metabolism that occur with the operation. The operations that we offer at Capital Regional Medical Center include the gastric bypass and the laparoscopic sleeve gastrectomy. The first operation that I will discuss is the gastric bypass. In this operation, we make about 5 small incisions on your abdomen, and subsequently we make a small pouch out of the stomach. We then reroute your small intestines to make a new connection between the gastric pouch and the small intestine, and then downstream between the small intestine. So you essentially have 2 new connections, the gastrojejunectomy, and further downstream you have the jejunojejunectomy. The way this operation works is to restrict the amount of food that you eat, but also cause some amount of malabsorption by bypassing the stomach and the small intestine for about 150 centimeters. Obviously, like I mentioned before, there's again hormonal changes that occur in the GI tract that cause patients to lose weight. This operation can result in a patient losing about 75% of their excess body weight in a span of about 1 year. This operation encourages patients to eat small portions of food and typically discourages eating sweets and other sugary foods. The second operation that we offer here at Capital Regional Surgical Associates is the laparoscopic sleeve gastrectomy. This operation again is done through about 5 small incisions, and we remove about 90% of the patient's stomach in this operation. So this operation, just like the gastric bypass, restricts the amount of food that you eat, but does not involve any rerouting of the patient's intestines like the gastric bypass. This is the most common operation being performed worldwide for patients who are morbidly obese. The main way that this operation works, apart from restricting the food intake, is to reduce the levels of a hormone called ghrelin, which is your hunger hormone, and which is also the hormone that causes patients to have cravings. By reducing the levels of these hormones by about 70%, patients can expect to lose weight by reducing their hunger and as well as reducing their cravings. The important point I want to leave you with from both these operations is that you don't lose all your extra weight with either of these operations. With the sleeve gastrectomy, you typically lose about 65 to 70% of the excess body weight. With the gastric bypass, it's about 75 and sometimes up to 80% of the excess body weight. Remember, your mileage may vary depending on how you do with diet and exercise post-operatively. Let me give you a weight loss example. If a patient weighs 350 pounds, but should weigh ideally 150 pounds, the excess weight is about 200 pounds. With a bypass, you would expect to lose about 75% of your extra body weight, which would be about 150 pounds. With a sleeve, you'd expect to lose about 65 to 70 pounds, which again would be between 120 and 140 pounds. So your final weight with a gastric bypass would be between 200 to 230 pounds, and with a gastric sleeve, about 220 to 225 pounds. You might lose a little bit more or a little bit less. I will spend the next couple of minutes discussing the risks of both operations. With a gastric bypass, the most feared complication is a gastric leak. This is typically evidenced in the first to second post-operative day, and patients who do develop a leak usually start getting fever, abdominal pain, have abnormal labs, and just don't look right. If this is the case, we take patients back to the operating room to typically identify and repair the leak. The other complications that can be seen with a gastric bypass include severe and excessive weight loss, causing patients to become very malnourished. This is rare, but if it happens, requires the gastric bypass to be reversed. The other complication that can occur with a gastric bypass is an ulcer that can occur between the new connection formed at the site of the gastric pouch and the small intestine. These ulcers can be typically treated with medication, but sometimes require a revision of the new connection for them to be resolved or to heal completely. Certain complications that occur with gastric bypass are unique to the gastric bypass and can stay with the patient for their entire lifetime from having the gastric bypass. This includes, but is not limited to, the ulcer that I mentioned previously, but also the risk and development of a small bowel obstruction through bowel creeping in between the defects created at the time of making the new connections during the initial operation. This risk of what we call an internal hernia can be life-threatening and needs to be identified right away. If this is diagnosed, an operation is usually performed within an hour or so of discovering the complication. Moving on to the laparoscopic sleeve gastrectomy. The commonly encountered complications, though rare, are usually bleeding at the staple line or a leak at the staple line, just as we see with the gastric bypass. Like I mentioned, both these complications are rare, and just as in with a gastric bypass, we usually look for things like bleeding as well as a leak at the end of the operation. With respect to the post-operative care in a gastric bypass, most patients spend about 2 nights in the hospital. On the first night, we typically start you with a clear liquid diet, and the second day after the operation, we typically start you on a pureed diet. You go home on the second day and you stay on a pureed diet for about 2 weeks. At the end of 2 weeks, we see you back at the office, and if you continue to do well, we advance you to a soft diet. Similarly with the gastric sleeve, on day 1, you start on a clear liquid diet, and you're usually discharged on day 1 with a gastric sleeve. On day 2, when you're at home, you will typically start a pureed diet and stay on this diet for about 2 weeks. Once again, we will see you back at the end of 2 weeks, and if you continue to do well, we advance you to a soft diet. Most patients are able to get back to a regular diet in about 3 to 4 weeks after the operation. Post-operatively, there are only 2 restrictions after either of these procedures. The first one is to avoid driving or operating machinery while taking narcotics. Most patients need narcotics for less than a week. The second restriction involves avoiding lifting anything heavier than 8 pounds or a gallon of milk for about 6 weeks. This reduces the chance of an incisional hernia forming in the post-operative period. Most patients are able to return to work in about 2 weeks. I also tell patients that it takes about 6 weeks to feel like you never had an operation. However, I can guarantee you that at the end of 6 weeks, you will feel like a new person and you will be glad you had the operation. It is very important by the end of the second week that patients also start taking their bariatric vitamins. This can be either something that's prescribed, which is a specific bariatric vitamin, or something that can be obtained over the counter from any pharmacy, something like once a day multivitamin tablets. For women, they can even take a prenatal vitamin. It is very important after a gastric bypass to be compliant with taking the postoperative vitamins, as nutritional deficiencies can occur and can make patients sick not only in the immediate postoperative period but even years later. With the sleeve gastrectomy, we recommend that patients take vitamins if possible for the rest of their life, but at least for the first 2 years after the operation. The point to take away from either the sleeve or the gastric bypass is that this is a lifestyle change from the time you have the operation. The patients who do very well are the ones who are committed to the dietary changes after the operation. And really, what do the dietary changes look like? It typically involves eating small meals, typically on a plate that we buy for 2- and 3-year-old children. We don't take second helpings, and we eat a high-protein, low-calorie diet. That typically includes avoiding junk food, avoiding sodas, avoiding sweet teas, avoiding fruit juices, avoiding excess of pastries, cakes, cookies, chips, the stuff that we all like to eat. The second piece of advice I give to patients regarding their diets is when you sit down to eat a meal, eat the protein in your meal first. So that typically includes eating the meat, the fish, the vegetables first. Usually try to fill up on the protein. If you do need a small amount of carbs, take a small serving of rice or bread or pasta or potatoes, not rice and bread and pasta and potatoes. We typically want to be having patients eat preoperatively a diet that is around 1,000 to 200 calories. Most patients don't realize this, but they're typically eating over 2,500 to 3,000 calories. After the operation, the restriction created by the gastric pouch or the sleeve gastrectomy will typically allow you to eat only about 800 to 1,000 calories in a day. That's why I emphasize the lifestyle change that goes into this entire process. If you start making the right habits before the operation, it will be easier to follow these habits after the operation, and you will not miss the foods that you craved before. The next bit of advice involves exercise. Exercise is not critical to success after the operation. It is diet. If you think about patients who are at nursing homes, most of these patients are skinny because they don't eat. They're not working out and not running a marathon. That's why diet is the Achilles heel in success after bariatric surgery. Those patients who stick to the diet do very well. Those who kind of relapse into bad eating habits will typically regain weight or may even get sick as a result of eating and making poor choices. Exercise is important for cardiovascular health, and we encourage patients to even start exercising before the operation, maybe a 20-minute walk about 2 to 3 times a week. You will notice that once you get into a place where you can exercise frequently, you will continue to do this after the operation, and you will improve cardiovascular health. As far as the benefits go, what my patients tell me is that in the first few weeks after the operation, they feel that energy levels have improved significantly. Young patients who have young children will usually tell me that they can start playing with their kids again and they don't get tired as much as they did before the operation. Sometimes I get questions about how quickly a patient can conceive after undergoing bariatric surgery. We usually recommend after a gastric sleeve or bypass to wait approximately 1.5 to 2 years to allow your nutritional requirements to stabilize before becoming pregnant. This ensures that not only are you getting adequate nutrition, but when you become pregnant, the baby also gets adequate nutrition. Remember that with a gastric bypass, the chances of malnutrition and nutritional problems for the fetus are slightly higher and less so with the sleeve. Another question we commonly get is whether previous abdominal operations are a contraindication or prevent patients from getting bariatric surgery. In our practice, we are rather comfortable doing advanced laparoscopic procedures, and we have done bariatric operations on patients who have had multiple previous abdominal surgeries, and we have been successful in accomplishing the procedure laparoscopically thus far. Finally, I want to talk about the pathway from the time you register yourself for bariatric surgery to actually receiving the operation. Once you complete this seminar, you have the option of either registering with our office to schedule to meet one of us, or we can also set you up with the bariatric center. Eventually, however you choose to go down this road, there are a couple of things that need to be done to ensure your safety and for us to ensure a safe operation through this process. After meeting us, we typically set up appointments with the following doctors. A cardiologist will see you to make sure that your heart is strong enough for the operation. Sometimes preparation involves undergoing cardiac testing and stress testing to allow us to know that you are a safe candidate for anesthesia. Similarly, we also set you up with a pulmonologist or a lung doctor who will check you for sleep apnea. If you do test positive for sleep apnea, you will be fitted with a CPAP machine to prevent you from having sleep apnea subsequently and going into the operation. We also have our patients see a gastroenterologist who will typically perform an endoscopy. An endoscopy is a test where the gastroenterologist will place a camera inside your stomach and make sure you don't have any ulcers, tumors, or polyps that would preclude us from using the stomach for bariatric surgery. Finally, we will also have you see a psychologist who will sit down with you and discuss your understanding of everything that we have just discussed to make sure that you understand that this is a lifestyle change and typically cannot be reversed once the operation is done. We also have this done to make sure that we screen our patients for undergoing surgery for the right reasons so that we can ensure a safe and good outcome for you. As part of the process to get you into surgery, we will also have you meet our specialists at the Bariatric Center. They typically include a bariatric coordinator, a dietitian, and an exercise therapist. All these members are part of the bariatric team to ensure that you undergo a safe operation with the best possible outcome for you. This is a multidisciplinary effort and requires the expertise of multiple people, of which surgeons are just a part. Typically, it takes about 3 to 4 months from the time you see one of us at Capital Regional Medical Center to the time of the operation. This span of 3 to 4 months is typically an insurance requirement where you undergo dietary counseling and meet the various specialists that I mentioned before. Thank you for being part of our seminar today. We wish you the very best on your bariatric journey. Please feel free to give us a call or visit our website. Thank you.